you have to well filter. And if after you've done that and you put electrode in, post-operatively, our practice is we continue IV antibiotics for about 72 hours if it's a leak, the significant leak. And otherwise, we normally give only for 24 hours. IV antibiotics. Just give one dose pre-operatively, one dose at each. Next day onwards, try from more. But if it's IV, if it's a leak, then we normally continue IV antibiotics for 72 hours. And after discharge, the child will oral.
Do you give cephalosporins in these cases?
All our first line
is not
coavascular, because we have found that practically coavascular is so abused. It doesn't work even 90% for
any rule of lumbar puncture?
Yeah, we've never actually had to have a lumbar drain till now for Cochlear implant. Only once have we done a lumbar drain, and that is for an ABI, for a pediatric brain where we had a significant leak. But that is a different thing. You're opening the training cavity. But here, from Cochlear, we never actually had to have ever a lumbar. Taking 3,000 cases or more actually had to do.
When you are doing otosclerotic, the advanced otosclerosis, then you have to do Cochlear.
Actually, I have a talk on advanced otosclerosis, but we talk about it. There's no big secrets there. In advanced otosclerosis, what are the challenges? The challenges is that you have knee ossification, just like you have in mental. Okay? And this knee ossification, you can pick up both by HRCT and by MRI. And the problem with knee ossification is that it can actually interfere with your electrode coexistently. And unlike in meningitis, where mostly it's the basal turn, here also the basal turn involved, but you can have the right and because the second turn also involved. So you may have difficulties with insertion. And the bigger problem is the electrical leakage of the bone. The otosclerotic bone is very porous for electricity. So a lot of patients will have stimulation outside the body. And you may have to identify them. So what are the common stimulations outside the body? One is the tympanic plexus. That nerve can get stimulated and patients can have deep-seated pain. That's one symptom that we complain about. The second thing that can happen is that it can cause facial nerve twitching, facial nerve stimulation. And facial nerve stimulation because you see where the second turn of Cochlear is. The second turn of Cochlear is just below the process of performance. And just above the process of performance is what? Genital ganglion. Right? So, what separates the genital ganglion from your implant is nothing but the process of performance, which is not a very deep structure. So, electricity can easily jump from second turn onto the facial nerve, and there can be facial twitching in the genital. So therefore, you may have to identify and switch off those electrodes. Normally, in the case of metal, it will be 7, 8, 6, 7, 8. Those are electrodes which will be second turn. And in Cochlear, it will be somewhere around 13, 14, 15. So you have to identify and switch off. So this is the other problem with
8, 11, 13, I think is the facial nerve flare. Dr. Baya was talking about patients with our country, seborrhea is very common.
Yes, it's a big problem.
And when we actually do the clipping a day before, I get all my patients completely clipped, like the clipper. And you notice seborrhea and you showed that staphylococcal infection. I think if I notice that the child has seborrhea, I postpone the child.
I think so.
So what we do is give fluconazole to these children and give that antifungal pain for a week, ketoconazole and shampoo, that Nizoral shampoo. Wait for a week's time.
Yeah.
When they come back, the seborrhea is gone. Because the one which you showed, the staphylococcal abscess there, always occurs secondary to seborrheic dermatitis, getting secondly infected with staph. So I think one should not take a chance. My
There are some very important points they have raised. One, do not hesitate to tell parents completely cut off the hair. I don't like this half hair, half thing they're coming with the mohawk hairstyle. So tell the whole thing, because this hair is a nuisance in our country. I don't know who told men and women there is a good thing, but whatever it is, it's cost a lot of money, a lot of people, nothing else, and it's a lot of information. So do not hesitate to tell parents. It's not a big problem in small children, but older people will be a problem. Sometimes it's, you have men and women, in their 30s, 40s who want cochlear implantation for whatever reason, and they'll make a big fuss. Can I take 4 inches, doctor, 6 centimeters? No, I tell them take it out and then come. I don't want to see it. So this is important because it's a big nuisance. Like Dr. said, you will find skin conditions, you will find all sorts of things, and they predispose to infection. And infection is the one bugbear that all of us are delicate about. So everything that can be done to reduce that.
These children, many of them, when we are evaluating them, they have otitis media with diffusion. When we are doing audiological investigations, we find that impedance is B-type, bilateral B-type curve, and we treat them for say months, say for a 4 weeks time. Call them again, come. I am talking about my protocol that after 4 weeks, suppose if it's still B-type, I go ahead, do a mylingotomy. And I just want to come to that I normally don't put in a ground. I just do a good mylingotomy. If need be, I do a counter mylingotomy so that I have taken out all fluid.
It doesn't really matter.
And the only question I'm asking is, these are all my doubts, that if you put a grommet, and this grommet, that grommet, you may have 30% chance of a post-tympanostomy tube otolium. So, and this grommet many times, you have to schedule your surgery. Suppose if it doesn't come out, or if it comes out with a perforation, then in the same setting you can seal the perforation. But suppose if there is otolium, this otolium you have to take some time to treat.
See, actually, it makes no difference whether you have a grommet or not. So, if you put a grommet in, and then normally in our protocol in our center, we would defer the second. So, what I would do is I would do mylingotomy and a grommet and a positive product in one sitting. Okay?
So you are not postponing them. You're
No. I'm deferring it in 2 stages. So, first stage, I tell the parents, look, there's going to be effusion. I've treated you medically for a month and nothing has happened. It's still effusion, but this child is a child for cochlear implantation. So, first stage, I would do mylingotomy, grommet, and a positive product. Why? Because positive product also is treatment for autism with effusion. But what do you do for resistant autism with effusion? You do positive product. So, you also do positive product, first stage. But I don't put the implant. I've got everything sorted out, it's all ready, everything is good. So I tell the parents, go home. Come back, close. Come back after I've done a follow-up plan, I've done post-processing, I've done a bed for implant, everything I've done, except putting the implant. So 1 month, 1.5 months later, I take up the child, second stage, I open up and it's all there. I just take away, clean up a little bit of granulation, enzymatic mucosa, whatever is there. I put the implant in and tie it up and I insert it, close up and come on. So the second stage is a much simpler procedure. It just takes 15 minutes.
During this 1 month's time, the child is on antibiotics.
Antibiotics and sometimes we use steroids. I give antibiotics for a week, not more than that. After that I keep them mainly on nasal sprays or whatever, topical steroid. And sometimes we give a short course, 5-6 days of course required. But usually nasal steroids and antihistamines.
I don't know what's your experience in any of these when you are after treating them for otitis media with effusion, even if the impedance has become A-type curve. When you go to do the posterior tympanotomy, there is excessive bleeding, and there is a layer of mucus which overlies your mesotympanic, and then you have to. And when you try to take that out, it starts bleeding.
Actually, audience effusion is a big nuisance.
Yeah.
A big nuisance because now we know in audience effusion also there is biofilm. Okay? It's another situation where biofilm can grow. So it's a pretty nuisance, and you really have to treat it very effectively before you think about putting in an implant. So That's the reason why when I do audit the patient management, I think it's not very flexible to also do personal productivity, give it a good wash, flush everything, and then have the grommet, and then second stage go back. It's usually much better. But it's very independent.
Why I said all these events actually happened in one of my patients. What happened? This child, 2 years old, we investigated B-type curve. I went ahead, did it in did a myocardial counter. It was all very thick, mucoid sort of thing. It wasn't coming, so the counter incision, the whole fluid came. I thought that, because I have never put a grommet. Around 15-20 patients, this works. So child comes back again after a month's time again with a B-type curve. Then second sitting, I put a grommet. I put a grommet after 3 days. They brought the child saying that profuse discharge. So I treated the child for the discharge and everything became okay. The grommet obviously because of this after came out. And then there is a residual perforation, small perforation. But now the discharge is not coming down. So it's a persistent mucosal disease.
Now what I would do is I would do a mastectomy.
Yeah.
No. I would do a mastectomy, post-dipperotomy, and leave the perforation. So allow the whole thing to heal.
Okay. So you have you do a first stage mastectomy.
First stage implantation.
Okay.
Yeah. So cardiac mastectomy, valve flap, post-dipperotomy, freshen the perforation. Don't put a grommet, leave it open, and go give it time. 1 month, 1.5 months. It's a traumatic perforation. It will heal. Once the discharge stops, the perforation will heal. And you got done a post-dipperotomy, done everything. Give time, 1 month, 1.5 months, let the whole thing settle down, nice, quiet. Then go back and everything.
So you would see the perforation.
No. You want this discharging now. So leave it open. Allow it to whole thing to settle down. Once the infection settles down, the perforation will go. The child is after all a traumatic perforation. Think of it like AOS. It's going to settle down. The only reason it's not settling down is probably there's an intermastoid they just allow that. Solve that.
Sometimes A-type implant you are mastered and CT scan shows cellular thing. You have to.
See, there are many things. See, one, the time interval between your CT scan and your surgery. See how many of us do a CT scan and post the patient for surgery within 48 hours, 70 hours. None of us. Let's be honest about it. Usually the child comes, you work up the child, and then it has to go for, supposing it's a scheme, it's going to take 2 months, 3 months, whatever. Supposing it's not scheme also, even if it's a private patient, he just has to go collect money, last week 1.5 lakh missing, I'll go private now. If it is a very wealthy private patient, he will look for a good day appointment with astrologer, all that stuff. So it's not your decision, it's a decision of a lot of people together. Grandfather has to come, grandmother has to come, uncle is coming to US, is going to come and land here, can you please wait for all of them to land, so everything. So there is a time interval, and in this time interval, a lot of things can happen. And artificial efficient can easily happen. So it's not a big problem. Which is also brings us to another important point. No matter what, adult, child, anybody, the day before your implant, the day you admit the child or the adult, please do a typograph on that day. It's compulsory. It must be part of your protocol. No matter what the procedure was before, even the drum looks normal. Do a typograph the day you admit the child and see how it is. If it's a typograph, fine. But even if you, as I said, even if you get a typograph, you get a normal CT scan, and you go back and you can still get flu. The reason is that a typograph is no guarantee that there is no flu. What is a typograph? It's a reflection of the impedance system there. And if your impedance system is good, in spite of your, if the vibratile properties of the pneumatic membrane are still good, despite the fluid, you can still retain it. If you look like an AS shaken. So it doesn't really mean anything. So you can still get glue. If you have very minimal glue, little bit, just 1 or 2 drops, you just suck out at the glue. I won't bother. I just go ahead and do it.
The mucosa is
no, mucosa is normal. It's not inflamed. But if you have a lot of glue and the mucosa is stage. So that is why also when you are counseling the parents about surgery, you have to tell them that the situation may warrant on the table that we may stay. You know, it must be part of your consent system. You must get a consent.
There is some literature that says that there is no contraindication to using grommets concurrently with implants also.
Absolutely.
Because I think it's just a ventilation view and it is going to improve the ventilation rather than.
I have done this also. I have done that. I have actually done that. I have done a grommet along with a mobile implant. When I felt that the drum was slightly retracted, you know, and I was not too happy with the situation. Not actually glue there, the drum was a little retracted, and I felt that this is going to give rise to trouble. I put a grommet in. See, remember, all this trouble is only for about a month or month and a half. If you can skip the first 1 month or 2 months, you know, if you can run smoothly, then there's no problem. Because you get a 2 months later, you go to take over. You have a beautiful capsule all around the implant, right up to the cochlear, inside the cochlear. You have a beautiful capsule right from the receiver stimulator to the, you have nice fibrous capsule, which is isolating it from the middle ear. So even if a child develops an acute dyspnea, nothing will happen to the implant. But my treat acute antibiotic, perigotomy, whatever, nothing will happen. It will recover. So the actual protection from infection is this capsule, fibrous capsule. So, but that takes about 2 months or 3 months to form. So that's the time when you are vulnerable, you know, when you have to protect.
And this is the indication for using the grommet. Most of it is start seeing a retracted pocket forming.
Put a grommet.
Put a grommet. Improve the ventilation of the ventilation.
See, a cholesteatoma in after a cochlear implantation is 100% hyperthermic. 100% hyperthermic. You can't blame anybody for that but yourself. Because how does it form? Only way it forms is if you have breached the annulus. And that can easily happen when you are scared of cochlear for the facial nerve. Because of the fear of facial nerve, surgeons tend to go laterally. And the chorda tympani is also the landmark of the annulus. So if you go laterally, you know, and go a little more laterally, you can cause micro fractures of the annulus. These micro fractures will later, years later, not immediately, but 5 years later, 6 years later, 7 years later, come back as cholesteatoma. So if you have a patient with a cochlear implant and also the cholesteatoma, no kidding, you know, you can't fool anybody. It is your
Suppose most of the children we operate after 4 or 5 years they get repeated expense to plan research. But still implants also. And because of the capsule formation of implants. And they sleep.
Yeah, that's where what Prabhu said. Ideally, you know, if you have a perforation, you can, you know, just treat them with IV antibiotics.
Suppose if it is not really perforation still.
Yeah.
The implant is doing that.
Yeah, just take a swab, see which organism is there, treat them with appropriate antibiotics. Just you just need conservative treatment.
As a child grows, the immunity changes. So they look for functional antibodies to identify what is actually causing the persistence of the weak or autoimmune. So ventilation when they are kept and treating appropriately the bug. It's a
No, I want to ask all of you. How many of you have experience with implantation in single-sided? Or how many of you single-sided?
I have done one.
You have done one.
In a patient with intractable disease. I actually kept on discouraging him that don't get it done. You are perfect. And just he said therapy and all that, and then gave it putting on.
But was it after sudden hearing loss?
It was after a idiopathic sensory hearing loss. We treated him, did not improve. We ruled out everything, all protocol.
But not suddenly.
Idiopathic, yeah, gradually. And then this fellow started saying that, I'm not bothered about my hearing, but I'm just my tinnitus now. And there was no other way. I said, people are now advising that, you wanted to do a cochlear implantation. It will have 2 effects. There is a chance that your tinnitus might disappear and you will probably hear better. So, after 3-4 months of all this, I said, you have to take a decision because, I'm not saying, you have to tell me that you want to listen. So I've done one. He was okay for close to 3-4 months. And then he came back again and started now, doctor, the tinnitus is again coming, not so severe.
It is soft.
Yeah, it's so soft.
Actually, we have a few patients in whom we have done single-sided deafness, where almost all of them were sudden hearing loss. Whereas Naresh said almost all of them, the indication was tinnitus, intractable tinnitus. One was a doctor, she was an ophthalmologist. She said, I just can't bear it. I don't care what happens. I almost think of suicide. That's how bad it was. So she said, please do it. So, yeah, it doesn't work, but at least I've given it a try. And it worked like magic. It worked like magic. Sudden hearing loss, if it's single-sided sudden hearing loss, today you have to counsel them for a Cochlear implantation. It works like magic. I can tell you, they're so happy. They get hearing back, the tinnitus goes, and they'll have excellent results. This is one group of patients in whom you should not have any hesitation in counseling for Cochlear implantation. If they have sudden hearing loss, it's not responded to medical treatment, obviously. The more gradual ones, this is what Naresh was saying, the idiopathic hearing loss, it is progressive and gradual over time, they are a little more difficult. That group, you will give them hearing, but tinnitus you cannot assure. Although many of them will tell you that the intensity of tinnitus is come down. They're still having tinnitus, the intensity is come down. So you can counsel them, tell them that your tinnitus may not go. It's a hearing that we can restore, we can't say about it. Because the problem with tinnitus is a lot of tinnitus is septal. And that's outside our control. I always remember one, I worked with a very distinguished otologist in London. He was Tony Cheeseman. He's an amazing guy.
He's written one of the chapters in Scott.
So I was working with him, I was his registrar, and then we took up a patient for cochlear neurectomy for tinnitus. I remember very well. And I mean, we're all aghast because we never heard of it, and he was doing it. So he went, and then opened out, it was we exposed the cochlear nerve, showed it to us, and then cut it out. We cut the cochlear nerves, let's see what happens. And this lady, I distinctly remember waking up from anesthesia, looking at me and saying the noise is still there. so it's central tinnitus, so you can't promise them anything. But generally speaking, it helps because peripheral overload of central circuits will also help in central tinnitus. It's like the phantom limb. So when you are stimulating a particular phantom limb, you have this feeling that this areas, a person who's got no leg will feel that the little toe is burning or itching. There's no toe, no leg at all, you are empty. But you will say my little toe is burning. That's a phantom sensation. Now in that sensation, if you actually have stimulation, electrical stimulation, they will very often that will go. So the same principle applies here also. So peripheral stimulation will cause central, the phenomenon to be suffering. So that's also one cause.
Meniere's disease, if you have.
We have actually now a whole series of patients we have done combined labyrinthectomy with cochlear implantation. So in resistant Meniere's, which is not responded to medical treatment, we do maximal medical treatment. We put them on diuretics for a year and everything. If at the end of it, the patient is still crippled by vertigo and also has profound hearing loss, then we do a counsel and do a labyrinthectomy with cochlear implantation simultaneously. Yeah, about I think 45 cases.
Can you do anything short of doing a labyrinthectomy by doing that thick and Cody's operation?
No, why should you? Anyway, you're going to be.
You just, anyway, whatever the vestibular
You can, but
destroy.
But that's not so reliable. When you are anyway going and doing a post-necrotomy, macerating, from there, labyrinthectomy is another half an hour. So you're much more sure. So we've got now a whole series of patients. They've all done very well. The vertigo has stopped, the hearing has come back, and occasionally they will come by, they will tell you that they still have that occasional fullness. I suppose it's a cochlear, that they are feeling. The fullness, they'll say, I had the fullness, but I got scared, but nothing happened. I didn't have vertigo. So they will not have vertigo. Vertigo will stop. Hearing will come back, and they will go. So it's quite worthwhile.
These attention deficit children, ADHD children. What do you do? Actually, it's a very catch-22 situation because you have done the implantation, they are still hypokinetic. You send them to the psychologist, they give them methylphenidate, which sedates the child. Parents will come back and say, child is always sedated. What do you do?
Very difficult. Actually, these children, if they also have profound hearing loss, the attention deficit will also get aggravated, and the hyperactivity gets aggravated when they have profound hearing loss conditioning there. So you have to talk to the parents, you have to talk to the psychologist, you have to have a combined discussion with all of them. I have seen a child who was classified as attention ADHD, who underwent cochlear implantation, settled down beautifully after that, and now she's actually a medical student in Chennai. Her mother is a pediatrician. Her mother is an ENT surgeon, father was a pediatrician. And because mother is an ENT surgeon, she understood the situation. So I said, now we have two options. Either we do an implant or we don't do an implant. We leave the child there. And mother said, no sir, I want to try. Obviously, I would say the same thing too. So we said, okay, we did an implantation. And the child settled down, the hyperactivity came down. Although she was still a bit hyperactive, but settled down. But the mother was so persistent, father is a pediatrician, he was very persistent. They went through rehabilitation 2 years, it was long 1 year. And end of it, child started developing language. And then after no going back, she just went off the tangent. And now, right now, she's a medical student. She's doing a medicine now. Excellent language.
Proper counseling of the parents is essential.
Very important, very important. And the parents have to be, realistic. In fact, the other side of it is cochlear implantation multiple handicap. Right? Classical example is Usher syndrome, deaf-blind, where there's a deaf-blind where the child is now, for me, there are only two emergency indications for cochlear implantation. One is Usher syndrome and the other is meningitis. Okay, these are two emergency indications. If a child has had meningitis and lost hearing, I tell the parents now the block is sticking. So start going in for implantation at the earliest. Don't be sitting and looking at astrological charts. Now time to go fast. The other indication is Usher syndrome. In Usher syndrome, you cannot sit and watch. You have to go in as early as you can. Because if the child becomes blind or most of the machines, rehabilitation is so difficult. Most of your rehabilitation after cochlear implantation is visually based, along with auditory stimulation. So they have to throw the charts, they're saying there's apple, that. So they need all the visual, connections. They don't have it very difficult. So these are two indications when you don't sit and wait.
What was your experience in auditory neuropathies?
We have a big number of patients who see cochlear implantation. See, what is auditory neuropathy? Auditory dyssynchrony. For the benefit of you have a trial. You have to one, of course, is the presence of autoacoustic emissions, complete disarray of the wearer, and absence of separated rhythms, and very poor speech discrimination. So these are the hallmarks of auditory dyssynchrony. Remember, the brainstem evoked response audiometry wearer is not a test of hearing. It's a test of auditory synchrony. It's really a test of auditory synchrony. In most people, the two are synonymous, but not always. Which is why somebody can have excellent hearing in auditory synchrony. Your audiogram will be almost normal, and yet you may have total dyssynchrony. And the only indication for that is poor speech discrimination. So, Vera is not a test of hearing, but Vera is a test of synchrony, auditory synchrony. So when that happens, in this situation, your auditory synchrony is diagnosed. You have two types of auditory synchrony. You have a peripheral type and a central type. The peripheral type is where the dysynchrony is mainly in it's mainly in the junction between the inner axis and the nerve endings. Okay, so that junction. Whereas the central type is much more central. The central type does not do well with peripheral type will do well. Fortunately, more than 75% autism is peripheral. 25% is not. So how do you discriminate between the two? How do you differentiate this? One of course is MRI. Because MRI may show some central pathology which will give you a clue of what's happening inside. But the more reliable tests are the EABR or the evoked auditory weight response, where you have an electrode which is put into the middle ear and then it stimulates the promontory near the round rotation. And you then record the parameter. It's an electrically evoked right stem response. And the EABR will then, if it is present, it tells you that it's a peripheral type. And these are good candidates for patient. So EABR is also a reliable indicator. Another reliable indicator, although not so easily available, is particular auditory vocalizations. The presence of good morphology in particular auditory vocalizations is also an additional, factor for prognosticating and saying they would be more or not. So all these factors are there and help you. But if you are careful about your choice and pick it up, you get very good results. Not regularly, but whenever we have a case like this, we will do it. Definitely do it.
We had a police plan. I think for 30 years, we had a trauma to the right side of the head and facial palsy. He was conservatively treated. Facial palsy improved on the right side, but he developed profound illness. Unfortunately, he says he was anti-terrorist activities. He was again involved in anti-terrorist operations and had trauma on the left side. So his hearing went on the left side, but his facial nerve was not affected. And he developed profound illness. Approximately after three months of this, he came to me and said, do something for you. Someone told him that you will go. So I advised that, okay, the only way for you is cochlear implantation. I'll do it on the left side. Radiological, everything was looking normal. It is okay. After I did the posterior deburotomy, I did not see any land. I saw there was some movement when I saw the short process, but inside, there was as if, no round release, nothing promontory, no white, there was a sort of a biofilm, white, I should say, grayish, yellow sheet of covering the promontory. The moment I touched that, I tried to touch it, it starts. So I was in a corner, I had opened everything and I know that this CT scan was there. So what I did was I took it there for, kept it for testing. And then I started dissecting from close to the oscillus from the round window side. And one side I could see the round window, this niche. Then I got confident. Then I did waves and a lot of ideas there. So I feel that I just thought that it was probably a remote impact. It got organized and became a fibrous But it should have been seen on the CT scan.
Yeah, it should have been seen
as a thick soft tissue. It wasn't seen. And that was another surprise.
One of the problems with CT scan is very seldom do a radiologist do a proper CT scan. 2 millimeter.
One cut,
most of them are 5 millimeter cuts. And you will have one cut in the base canal, and next cut will be somewhere in the mid-brain.
Normal acceptance.
No, you can easily. So that's why we now we have a protocol for our CT scan. We tell our centers and do for us. We want like this, and also now because they got image guidance and all that, they have certain protocols to follow them. So we tell them you have to do 1 millimeter cut, 2 millimeter cut. Otherwise, don't do it. But because we are the private sector, we have some control. They as well as know that if they don't do it, we send it to some other scan center. So they are. But in the institution, it's very difficult. It's very difficult because the professor of radiology is not a big man. If you are a big man, he's also a big man. So he will say, no, what the hell are you talking about it? Or what are you interested in? Information. I'm giving you information. That's kind of activity level. Very difficult. I know what you want.
If there are no more questions, thank you very much to Dr. Commissioner. And great thanks to Dr. Raidu and his team for arranging thank you. I have been
Excuse me, sir.
quite a bit.
Sir, sudden sensory neural hearing loss unilateral. Medical management for how many days will be giving?
It's a very good question. It is for sudden sensory hearing loss, how long are you going to do medical management? See, our protocol is we admit the patient. Okay, we put them on IV methamphetamine and intranet. Intranet panic will give 3 intranet panic medications or 3 conjugates, and IV methamphetamine is not about 1 gram per day, and we give it for 3 to 4 days. After that, we put them on oral, that is on 60 milligrams, tapering over a course of 4 to 6 weeks. And at the end of it, we do a audiometry. If in 3 months, there's a hearing, at 3rd month, you check up, and then you see whether the hearing aid trial is given. If hearing aid will not help, then these are the people who will be responsible. If after 3 months they have not recovered, I think the chances are very, very more than ever before after. 3 months is the reason.
Thank you, sir.
We do additional things and this sudden sensory hearing loss. Is that we put a nitroglycerin patch. And nitroglycerin patch, what Dr. Mohan said is IV prednisolone, followed by nitroglycerin patch for 7 days time. In addition, what we have started doing is giving these patients methoxycobalamin for a month's time, 1500 microgram. This came out of 2 patients. There was a patient who's being treated outside Chandigarh, outside PJ, by one of my colleagues who is now practicing. So he is following the same protocol. So he got all the treatment and nothing happened for around 3 weeks time, no improvement. So he somehow, they want to have second consultation. He came to me, I said, you have been treated adequately, I have nothing to offer. But as a placebo, I can give you something. This is around 3 years back. So I gave him methoxycobalamin, 1500 microgram per day. I told him take for 1 month and come back after 1 month and see. By that time it would be 2 months, we'll see. And to my utter surprise, he came back after 1 month and there was a 40 decibel improvement in bone conduction.
Actually,
I don't know, this may be just many a time as Dr. Mohan said that you should wait for 3 months because delayed recovery is no.
Right, no. Happen easily after 1 month or 1 month. I think there's no harm in adding it with the So that's one option. There's no evidence for acyclovir. I think it's pretty much gone now. I still see some surgeons, prescribing acyclovir, but there's very little evidence. In fact, there's no evidence. Let's be honest about it. There's absolutely no evidence that acyclovir helps. So don't waste your time with acyclovir. Antivirals have no.
The patient comes within 48 hours of his hearing loss. Actually, we were sending blood for antibodies to measles and mumps viruses, and we found that I think 46%. I don't remember. This is quoted in our article is published and quoted in Cummings. That 46% of these patients have positive antibodies, and that's the rationale for giving acyclovir, or nowadays valacyclovir is better than acyclovir. You can give valacyclovir for 3 to 5 days to those patients who present early. If he has come after 5 days, then there is no hope.
I don't know ask this, but the only other thing which some people have tried again with very mixed results is hyperbaric.
These armed forces people have, I think.
If you have access to hyperbaric, then you can give hyperbaric oxygen also. Anyway, I think the main drug is, all the others are additional. I don't think it's adding it or subtracting it makes a huge difference.
But as you said, intratympanic dexamethasone is a good.
It's a very good thing. And there are many studies that have shown that nothing else excepting intratympanic has shown very good.
Yeah.
So intratympanic is definitely a must have. 3 doses maximum. Over 3 days. Along with, because if you can keep them 3 days in a ward, and you can give 3 days intratympanic and also give them major prednisolone, that's adequate therapy. So 3 months you wait, and if at 3 months, end up at 3 months, the fellow is still complaining of tinnitus, and he says about having
Excellent.
We have the idea of injecting glutamathione at the level to reduce symptoms. John Shea has shown that symptom.
That's now out. She has thinking about that is now out. In fact, she himself did not impacted that. So the only indication for gentamicin tympanic is when you want to ablate in many years. But that's a situation where there is no healing. But I think even that, I nowadays, if somebody comes with many years, 6 months of maximum medical therapy, which is usually be diuretics, and salt is for 6 months. And if end of 6 months, the patient still has vertigo and hearing loss, is profound or severe to profound, not responding to any pain, that would be the candidate for reliable technique with consultation simultaneously.
Study in the UK, it got published in Lancet, comparing intratympanic gentamicin with intratympanic steroid, comparing double-blind randomized controlled trial. Variants for advanced refractory mania. They found intratympanic steroid works better.
Nowadays, intratympanic steroid is definitely.
We did a study even with once you quoted now. We did a study comparing the same, but we could not publish it in the international journal because, as per the American Academy guidelines, you cannot proclaim cure for Meniere's disease unless you have had a follow-up of 2 years.
Yeah.
So our follow-up was 1 year. Our patients improved 80% with intratympanic dexamethasone, but we had a follow-up 1 year, and they said it is not as per the guidelines.
And the reason is that in Meniere's is one condition where there's so much of natural recovery in a natural history. That's why all the sham operations are work.
Lymphatic
Anything you do, you can make them all right. You can give them methyl prednisolone, you can give them methamphetamine, you can give them nicotinic acid, everything gets better. So that's why it's one of those conditions where you cannot actually, everyone will be swearing by some drug, they'll say, I give this, it works, I give that drug, but as he says, 2-year follow-up, a lot of those things will go to the window. Even beta histine, cinnarizine, prochlorperazine, all these drugs are not recommended for Meniere's. They are only recommended for control of vertigo. And that's it. So once the vertigo acute phase settles down, there's no more scientific evidence for any of these drugs. Although every company will be coming up with some study done in Belarus or some study done in some center in India, which is hardly worth the paper it is on. So supposing I say, look, I have treated 300 cases of Meniere's disease with beta histine and 290 have got well, it means nothing.
Many of the patients with Meniere's disease who are on prolonged therapy with beta histine, thanks to the neurologists and other physicians, are actually having vertigo because of the effects of beta histine. And you ask them to stop for a while and then taper the beta histine, ask them to do VRT. They are better off. They come back after 2 months, say my vertigo is much better after I stopped.
Actually, a lot of this, high thing is high. You don't have to be, and there's actually no scientific logic. If you say you have to take a drug for 6 months or 3 months for vertigo, the only drug which is really indicated is a diuretic. And that too, not every day, probably give twice a week or, but our protocol is initially in the acute phase of vertigo, we put them on some vertigo suppressant and we keep them on alternate day diuretics. And our drug of choice is indipamide, indipamide. After 1 week or 2 weeks, we would then make it twice a week. And then after about 3 months, if there's symptoms, we make it once a week. Indipamide. And then indipamide is naturally accessible. It's a sustained release diuretic, very good grade, which you can give once a day. And it works out. The advantage is it's very gentle on the heart. It's kind of protective. And the other big advantage indipamide has is that he will not be making you rush into the toilet, so it's a very
once a day.
Morning. So you just give it in the morning and it will work very gently over the course of the day. So you can give it twice a week, and eventually long term I give them once a week for 6 months. That's it. So Natflix is a good drug.
Okay, I think from Cochlear implants we have come to media. So let's stop now. And thank you very much, everybody.